and his area of interest is teaching, and he has recently launched Fellowship in Pain Management, and also his special interest is in CT-guided interventions. Over to you, Dr. Bangar, sir.
First of all, I'd like to thank organizers, Dr. Varsha, Kenya madam, and also thanks Surbhi for exchanging my time. And now I'll start with the presentation. The pinched nerve path navigating nerve entrapment and ulnar nerve entrapment. Is my screen visible?
Yes, sir. It's visible.
Okay, fine. Thank you. So now let's see what are the learning objectives. I'll finish it within 20 minutes given a stipulated time. We'll be looking for ulnar nerve formation, root value, important relations as far as the pain conditions are considered, motor and sensory supply, various important sites. There are 3-4 sites where ulnar nerve can be entrapped. We will focusing on the commonest sites. What are the effects of injury of ulnar nerve and how we clinically test the ulnar neuropathy. So let's go ahead. Now, ulnar nerve, the root value is C at T1. So why you need to understand this is because any pathology or radiculopathy at C at T1 might cause is one of the differential diagnoses for the ulnar nerve entrapment. In the axilla, there are no any branch. In the arm, it gives branches to the elbow joint. So I hope you can see. Now, in the forearm, it gives various branches, one to flexor carpi ulnaris and flexor digitorum profundus medial half. So these are the two motor branches. And in forearm, it gives one more branch, that is dorsal cutaneous branch. So while entering from arm to forearm, it goes through a tunnel, and that's called cubital tunnel. We'll see what it is. Now, when entering into the wrist hand, it goes through the Guyon's canal. And this is important thing. A dorsal cutaneous branch is given just before entering into the Guyon's canal. And when it enters into the wrist, it gives the branches to the wrist joints. It supplies medial 1/3 of dorsum of hand and dorsum of medial 1/3 half digits. Palmar digital branches to medial half digits. All palmar and dorsal intarsis, third and fourth lumbricals, adductor pollicis, and muscles of hypothenar eminence. Why this is important is if the ulnar nerve, if ulnar nerve gets impacted just at the level of Guyon's canal, then the dorsal cutaneous branch will be spared and the sensation of this area, dorsum of medial 1/3 of hand, will be intact. So we'll see what it is. Cubital tunnel syndrome results from the compression of traction on the ulnar nerve at the elbow region. Right? How is the cubital tunnel syndrome formed? It is by medial malleolus, olecranon, and there is a fascia in between. Okay? And if it gets compressed at this level, it is called as a cubital tunnel syndrome. Okay? It is the second most common upper extremity compressive neuropathy. And as you know, the first is the medial nerve or the carpal tunnel syndrome. Now, there are various causes of ulnar nerve entrapment around the cubital tunnel. So we have seen that this is a cubital tunnel. The first is arcade of Struther. This is an arcade of Struther. It is nothing but a connective tissue between the tricep and intermuscular septum, just 6 to 10 centimeter proximal to the medial epicondyle. This is not the commonest site. Commonest site is at the cubital tunnel. Arcade of Struther is different from ligament of Struther. Ligament of Struther is responsible for the compression of median nerve in the arm. Second is a compression at the posterior to the medial epicondyle, and as we see that it is covered by the ligament, and that's called as Osborne's ligament. It runs between the medial epicondyle and olecranon or carpi ulnaris. Okay. Now, the compression occurs at the cubital tunnel, and this is called as cubital tunnel syndrome. A third site where the ulnar nerve gets entrapped is when it enters from the cubital tunnel. We'll see it on the ultrasound. When it enters through two heads of flexor carpi ulnaris, and that is one of the site where the ulnar nerve can get compressed. Now, if we see a cross-section of cubital tunnel, we can see this is a medial epicondyle, this is olecranon, this is a fascia, and it is an ulnar nerve. Now, what happens is when we flex the elbow, there is a significant compression of the cross-sectional area of the cubital tunnel, and then when flex elbow, there is a chances that ulnar nerve could be more compressed, and this is one of the provocative tests because in extended elbow, there is a cross-sectional area increases, while in flex elbow, the cross-sectional area decreases and ulnar nerve gets compressed. Okay. So what could be the clinical symptoms, signs, and examinations? It could be any motor or sensory weakness amongst the distribution of the ulnar nerve. It is very simple. What are the signs and symptoms of compression, a motor or sensory weakness along the distribution of the ulnar nerve? Okay. So what can be a various history and examination? Patient will have decreased sensations, okay, and that sensation, decreased sensation or pain becomes worst when the elbow is flexed for prolonged time. Okay. In general, bending stretches the nerve and exaggerates the symptom, while extension relaxes the nerve and decreases the symptoms. Right? A patient may report a weakness in the hand, a manipulation, a smaller manipulation could be different, and there will be finger abduction and adduction. Again, there will be loss of sensation of medial one half of the ring finger and the index finger half. Okay. There could be a wasting and atrophy of first dorsal interosseous muscle. Okay. What are the various signs? A Waterberg sign is positive. So this is a normal hand, and as you can see, a little finger cannot be actively adducted because of the weakness of the third palmar interosseous muscle, which is innervated by the ulnar nerve. And that's why abduction of the fifth finger due to ulnar nerve palsy is called as a Waterberg sign. Fromet sign is patient is not able to hold the piece of the paper straight. So it is compensated by the thumb to reduce the pull on the paper by flexing the IP joint. So this is a Fromet sign positive. And normally patient can hold like this, but if there is an ulnar nerve compression or ulnar neuropathy, then the proximal IP joint has to be used by the patients. Okay. Then there could be a claw hand, because in most severe cases of ulnar neuropathy, clawing of the fourth and fifth fingers occurs due to the functional flexor digitorum profundus and loss of the intrinsic muscles. What are the provocative tests? So Tinel sign will be positive. If we tap on the cubital fossa to cubital tunnel, then there will be a provocation of the symptoms. This Tinel sign will be negative in case if there is a C8 radiculopathy. Okay. Elbow flexion test. As we saw, the flexion of elbow increases the symptoms. Again, the elbow flexion test. This is a provocative test which will be negative in case of C8 radiculopathy. Okay. So, ulnar nerve stability test. We determine the nerve stability by placing the finger posterior to the medial epicondyle and to see if the ulnar nerve subluxates or if the nerve is stable throughout the flexion. We keep a hand on the tip of the index finger just below the posterior to the medial epicondyle, and the elbow is flexed. We see whether the nerve subluxates or remains stable there. Different treatments like NSAIDs, physical therapy, bracing, elbows, activity modification. These are the non-invasive. And invasive one is an hydrodissection and surgical. So now we'll see how does the ulnar nerve enters into the hand. So after it travels down the ulnar nerves enter the palm of the hand. At the wrist, ulnar nerve and the artery lies in the canal formed by the pisiform bone medially. I'll show all these figures, and the hook of hamate laterally. Okay, that's called as a Guyon's canal. And in this region, the nerve divides into two branches, the superficial sensory branch and the deep motor branch. So see, This is a pisiform. This is medial side, a lateral side. So you can see the pisiform is medially, hook of hamate laterally, and the ulnar nerve enters into the Guyon's canal. Now it gives two branches, one a superficial sensory and deep motor. Okay, so keep this three branches into the, not three branches, three structures into the mind. Ulnar nerve enters and divides over here. It's very important. Why? As I'll show you. See, so what we saw is just like a Guyon's canal has one proximal entrance and two distal exits. The exit, one superficial is a sensory branch, motor branch is a deep branch. Again, why this is important? We'll see that. What are the boundaries of Guyon's canal? The floor is formed by the transverse carpal ligament. Roof is by ulnar carpal ligament. We'll, again see all these things into the ultrasound. And the ulnar border is by the piezo-hamate ligament. Radial border is by the hook of the hamate. So you can see a VCL, TCL, a pisiform. This is very important. Now, this is medial side, this is lateral side. This is how the ultrasound picture will be seen. You'll see a pisiform bone. You'll see a VCL. You'll see a TCL. You'll see a ulnar artery, and just medial to the ulnar artery, you'll see a ulnar nerve. Ulnar artery will be pulsating. Okay, and lateral to it, you might see a hook of hamate. So keep this in mind. You will see the pisiform bone, hypoechoic area, then two ligaments, and in between these two ligaments, we'll be able to easily see the artery and the ulnar nerve. Okay, so why it's important clinically to know where is the lesion? So in Guyon's canals, there are basically three zones of compressions. Zone 1 is a location which is proximal to the bifurcation. So if the ulnar nerve gets compressed over here, what will be the signs and symptoms? It will be the mix, both sensory and motor. Okay, and what are the causes? Some ganglion and hook of hamate could be a fracture of hook of hamate could, cause a compression over here. So if the compression is just before the bifurcation, there will be the mixed symptoms, sensory as well as the motor. So superficial sensory, deep motor branch. Now zone 2. So it is a compression to the motor branch only. So what will be the symptoms? Symptoms will be mainly the motor symptoms will come and the sensory symptoms will be spared. So this is how we have to diagnose where is the ulnar nerve compressed. Is it distally compressed or proximally compressed? Distally means at the Guyon's canal, or proximally means at the cubital tunnel. Even if it is distally, so how to differentiate whether it is zone 1 if it is just before the bifurcation, zone 2 at the motor branch, and if it is only zone 3, then there will be only a sensory symptoms and the motor symptoms will not be there, while the cause could be the ulnar artery thrombosis or aneurysm. So if ulnar nerve is compressed at the Guyon's canal, as we have seen that the dorsal branch, dorsal palmar branch sensory exists just below the, just proximal to the Guyon's canal. So the sensation of the dorsum of the hand will be absolutely intact. So we have to differentiate whether it's high or low ulnar injury. How? High ulnar injury, there will be less clogging, sensory deficit of the dorsum of the hand, as we have seen this. And if it is cubital tunnel syndrome, Tinel's sign could be positive and elbow flexion could be a positive. But if it is at Guyon's canal, Tinel's sign at the carpal at the tarsal tunnel, cubital tunnel, and the elbow flexion test will be a negative. In low ulnar injury or the compression, the flexum digitorum profundus muscle is working. So flexing the fourth and fifth fingers and causing the clawing. We see the FDP medial half is supplied into the forearm. Again, a dorsal supply cutaneous branch arises before the Guyon's canal. So if the compression is at the Guyon's canal, this sensory supply will be intact. Now we'll see a few videos. We'll just revise before seeing the videos. anatomy once. C8T1 is root value. Axilla, there are no branches. It will be just medial to the brachial artery. At the elbow, it will give branches to the elbow joint. Into the FCU, it will enter the elbow through the carpal cubital tunnel, and then it will exit between the two heads of flexor carpi ulnaris. It will give a branch to FDP, and then it will give in a forearm one branch, a dorsal cutaneous branch, and then it will enter into the wrist through the Guyon's canal, where there will be a pisiform, hamate, VCL. Okay, so it will be just below the VCL, and there it will divide into the superficial and deep branches. So we'll see the videos. Now, I'll explain you everything. So, the probe is kept at the cubital tunnel. This is a medial malleolus. This is an olecranon, and you can see a Guyon's canal here. This ligament is a Opson's ligament, and in between this Guyon's canal, you can see the structure. This is a ulnar nerve. So if we trace the ulnar nerve, so I'm going to trace the ulnar nerve. Very nicely, the ligament is seen, medial malleolus and the medial epicondyle and the we'll see. Okay, wait. Now, I am going distally. As we go distally, you can see there are two heads of flexor carpi ulnaris. This is one head. This one is another head. And this is a ulnar nerve. Here is a second site where the ulnar nerve can get compressed. Did you appreciate it? This is an ulnar nerve. Just keep a watch on the ulnar nerve now. This is an ulnar nerve. So now we go more distally. The moment we go more distally, the moment we start going distally, you can see the ulnar nerve, and the muscle above is a flexor carpi ulnaris, and you can see the ulnar nerve. Now what happens is, as we go, ulnar nerve is accompanied by the ulnar artery. So we are going, I think we can see a very nicely ulnar nerve. And as we go distally, you can see ulnar nerve will, can you see this? Now very nicely, when we see the ulnar nerve is accompanied by the ulnar artery. Ulnar nerve lies medial to the ulnar artery, and those goes hand in hand and enters into the Guyon's canal. Before entering into the Guyon's canal, at the distal forearm, we see that it gives one small branch, and that is called as a dorsal superficial sensory branch. And we'll see, I'll show you the dorsal superficial sensory branch. You can see the ulnar artery coming. Now here, if we see, you can see few fascicles exiting from the ulnar nerve. Yes. Then we'll take some jelly. We'll go. So when it enters into the, going more distally, just keep a watch on the ulnar artery and the ulnar nerve. Now, this is at the level of the wrist. So it started entering into the wrist and into the Guyon's canal. Pulsations of the ulnar artery, concentrate on the pulsations of the ulnar artery, the ulnar nerve, and you'll see now the pisiform bones come in between. As I go, yes. So you can see the pisiform bone nicely, ulnar artery, ulnar nerve, VPL, and this is a second commonest site where the ulnar nerve gets compressed. Can you see the pisiform bone? Pulsations of the ulnar artery. Pisiform, ulnar artery pulsations, ulnar nerve, VCL, and this is a site of hydrodissection at the Guyon's canal. Nicely, ligaments are seen, ulnar artery pulsations are seen, ulnar nerve is seen. Now, what if we decide to trace the ulnar nerve just above the elbow? Again, medial epicondyle, ulnar nerve, Osborn's ligament, olecranon. And what happens if we trace it above? We can trace it very nicely, proximally. By the way, this is a site for the injection for the cubital tunnel. And when we press it, you can see the ulnar nerve nicely. Now we'll go more proximally. And as we go more proximally, the ulnar nerve goes and sits on the top of the tricep muscle. So this is ulnar nerve sitting on the head of the tricep muscle. And as we go towards the axilla, it will be accompanied by the brachial artery. Can you see the brachial artery? The ulnar nerve lies medial to the brachial artery. This is how we trace the ulnar nerve. See, you again can see the brachial artery coming from laterally. These are the pulsations of the brachial artery. This is an ulnar nerve. So now, wherever ulnar nerve gets compressed, inject it there, either at the Guyon's canal or at the cubital tunnel or anywhere at the entry of the carpal tunnel, at the entry between the two heads of the FCU. So depending on the symptoms, how we diagnose it, ultrasound, clinical examination, in case of few cases, NCV, EMG, and MRI. These are the few MRI neurography. These are the few diagnostic tests for the diagnosis of antral nerve entrapment. And the ultrasound guided in-plane approach is preferred. So at the level at which the ulnar nerve is entrapped, and if not, then surgical exploration or surgical repositioning in some cases might be needed. Thank you very much. I hope you understood. Dr. Archana, it's to you. Exploration or surgical repositioning in some cases might be.
Thank you, sir. Thank you, sir, for this very nice demonstration and a very informative lecture. Now I would like to go to the participants. If there are any questions for sir.
I'll stop. Skin scanning stop.
Yes, sir. Yes, sir. It's stopped.
Yeah, I'll stop it. Yes,
hello?
Kashinath. Yeah, can I ask a question?
Yes, ma'am.
Archana?
Yes, ma'am. Yes, ma'am. Please.
Yeah, Kashinath, wonderful presentation and in detailed. Good, very good. I just want to know, does anconeus muscle at the elbow has any role in causing a compression of ulnar nerve in cubital tunnel?
Madam,
any idea, any literature on that, or any?
I have not searched about the literature about the anconeus muscle, but what I found in literature is the ulnar nerve can get compressed anywhere, right from the any existing muscle, any small spur, any small osteophytes, any hypertrophied muscle, even the ulnar artery aneurysm, thrombosis that can cause, but anconeus muscle I have not came across.
Okay, because I mean, one of my patient had ulnar nerve entrapment, and with radiology, I mean MRI, they wanted to do dynamic MRI, and
Right.
with that flexion and extension, they could see that it was the anconeus muscle, which is usually absent in most
Exactly.
of the human beings, but presence of anconeus muscle might cause
Yes.
compression. That's what they had an opinion.
Yes.
One more thing, what is in your opinion, what is the good way or best way to deal with compression anywhere? What is your opinion on that, or what
Depends
do you
on the
do?
symptoms, madam. They have it depends on the symptoms, whether mild, moderate, or severe, and the pathology. If pathology is repetitive movements or which one can be corrected easily, then non-interventional managements, partial flexion, splinting in the partial flexion elbow, and the NSAID simply works. If the so we had patients where the ulnar nerve was entrapped in between the scar of 5 centimeter. They had some RTA, and that was not possible to hydrodissect whole of this nerve. So depending on the symptom, if mild, not responding, we can go to the intervention. And if we found that pathology is something which cannot be treated without surgery, then surgical intervention. They say that with surgical
intervention in the
depends,
not surgical,
depends,
in between. In intervention as a pain physician, what would you prefer?
Madam, hydrodissection. Simple hydrodissection.
Hydrodissection.
Hydrodissection at the respective level. Depends on what level the ulnar nerve is. So fortunately, what happens is, we had an ultrasound, and you can easily come to know where the nerve is compressed, of course, with the clinical findings, and we just can put, a lot of fluid around the nerve.
Any preference of the fluid? 5%, 12.5, 25%, PRP, steroid, or normal saline?
Lignocaine with steroid is what my preference is, but we can go with the 5% dextrose as well. We should not be exceeding the concentration more than 10-15% for the hydrodissection. Right. Regarding the volume of the drug, again, it depends on what is the level of, as I said, one of the patient, we tried in that patient, but we couldn't. The scar was long enough. So you have to, hydrodissect whole of the path. So if we are keeping in mind about the toxic dose of the local anesthetic, we can dilute it. Then we can go and hydrodissect whole path, depending on, what is the pathology.
Yeah. Thank you.
Thank you.
Wonderful presentation again, Kashinath. Very nice.
Thank you.
Good one.
Okay, so if there are no more questions, let's move on to the next topic.
Hello. Hi. Yes? Can I ask a question?
Yes, ma'am. Go ahead.
Yeah. Hi. I'm Dr. Kalyani. My question was to Dr. Kashinath, sir.
Yes.
Yeah, sir. As you said, there is an entrapment. If the entrapment is proximal to the Guyon's canal, so the sensory part is spared, right, sir?
I'll show you the. So what happens is a dorsal cutaneous branch.
Yeah. Sir, can I complete my question first?
Okay, sorry. Go ahead. Please go ahead.
Yeah, sir. And another thing was zone 2 of Guyon's canal. That you said that it affects the motor part of the nerve, and the motor loss is there, but the sensory is spared, right, sir?
Right.
So how do we differentiate between these two conditions where there is sensory loss?
Yes. So nerve, dorsal cutaneous branch, it supplies the dorsum of the hand, which exit above the Guyon's canal or proximal to the Guyon's canal. And the sensory nerve into the Guyon's canal supplies the palmar branches. So if the dorsum of the hand is spared, that means the compression is at the Guyon's canal or any level below the dorsal cutaneous branch is exited. Am I clear, madam?
Oh, okay, sir. Yes.
So dorsal cutaneous branch exit above the proximal to the Guyon's canal, it supplies the dorsum of the hand. One medial 1/3 and 1.5 digit. While the sensory supply, which occurs through the nerves, which is at the Guyon's canal, supplies the palmar digital branches, palmar side.
Okay, so we differentiate whether the
it is correct. Correct.
Sir, and if the how far above the Guyon's canal can we look for dorsal cutaneous branch compression?
Okay, so it depends on the machine. If there is, hockey stick probe, you can literally go quite far away. Unfortunately, I had used it, but as a demo piece, not into the actual patients. If there is a hockey stick, we can go quite far away.
Thank you, sir.
Okay.
Okay, so let's move on to our next topic, the radial entrapment syndromes. So this is another topic which is a bit controversial and also confusing. And we are very glad to have with us very eminent speaker, Dr. Madhan Pandian. He is known for his sheer passion for musculoskeletal ultrasound and chronic pain interventions. And he has been able to deliver standard of care in pain management in Pondicherry, India. Dr. Madhan Pandian has a great passion for educational activities, which is reflected in his active participation, presentations, workshops, and publications. He is an editorial member of Nizora and has been a major contributor to the US Pain app. Dr. Madhan Pandian is a frequent national and international speaker and has received many professional and academic awards. He has been a great contributor to pain education globally, and he has been instrumental in forming the Musculoskeletal Ultrasound and Pain Society in India with the aim of streamlining pain education. So over to you, Madhan, sir.
Thank you so much for the introduction, Dr. Archana. Right. Yes. And let me share my screen actually. Is my screen visible? I'm not able to share anything.
No, not yet visible. You are the
co-host. I'm not able to share.
You are the co-host, sir. You can share. Can you see the green share screen button?
Yeah, I'm just trying to share it. Just one moment.
In the meantime, Archana, can we take a question?
Yes, ma'am.
There
is one question in the chat box. But I think
Kashinath.
Kashinath sir is he there still with us?
Yes.
Yeah, he's there.
Okay. So it's about ulnar nerve injection. Do we inject medial to lateral or lateral to medial? Medial to lateral or lateral to medial to avoid hitting the sensory branches?
Avoid the ulnar artery. And ulnar artery lies medial to the ulnar nerve. Ulnar nerve lies medial to the ulnar artery. So try to avoid the ulnar artery. See, we are using the particular steroid most of the time. So hitting the nerve, entering into the nerve and hitting the artery, these are the different things. Even if we put some amount of local anesthetic, which goes, around any branch, either motor or sensory, it's probably not going to cause a lot of trouble. But if it goes into the artery, then probably a particular steroid, especially, that could be a little troublesome.
Okay. Thank you, sir. Sir, meanwhile, can I ask you a question? Bangar, sir?
Yes.
Okay. Sir, we often in entrapment...
Vichara?
Yes, sir?
Nothing, go ahead.
Yes, sir. Sir, often we ask patient to splint, sir. Right, splint that part. So they ask when should we splint? Like all the time it
At
should
night.
be splinted.
Especially at night. It is advisable, especially at night. During the day, it becomes difficult, and it should be at the flexion, because not flexion. It should be a little bit of flexion, not completely extension. So whenever possible, extension could be little difficult, and at night.
Okay, at night. Okay, thank you, sir. Thank you so much.
Yeah, and that is really very useful, because I have seen, I myself had a ulnar nerve compression on the left hand.
Acha.
It was swollen like 1.5 times, and radiologists say it's an anconeus muscle, maybe because they couldn't find any other pathology.
Oh.
Only thing, it was swollen by 1.5 times.
Oh, yes.
And that splint helped a lot. Yeah, started.
Right. So we have to compare it on both the sides to see whether it's swollen or not swollen, and what level it is swollen.
My both ulnar nerves are swollen 1.5 times, but symptoms on the left side.
Okay.
And I use splint as well as steroid therapy.
Acha.
I was about to do intervention. Yeah, oral steroids. I was about to do interventions, but then with steroid and high dose of vitamin B12 helped.
Oh, okay.
Okay, so
but yeah, I still have. Yeah, we'll start.
Okay, so we will take up the topic of carpal tunnel syndrome, which is one of the commonest upper limb neuropathies, entrapment neuropathy. So with us, we have Dr. Surbhi Bhagat ma'am. She is a founder director at Prabhi Specialty Center, Borivali, Mumbai. She is also affiliated with many hospitals in Mumbai, such as Wokhart, HCG Cancer Hospital, Sun Hospital. And she has completed her diploma in musculoskeletal ultrasound from Spain. She has done a fellowship in ultrasound guided regional anesthesia from Royal Derby Hospital, UK. Her areas of interest are teaching USG guided pain interventions and creating awareness on importance of acute and chronic pain management. Over to you, Surbhi ma'am.
Thank you, Archana, for that nice introduction. Thank you, Varsha, for inviting me to this meeting. I thank SSP Pune, Kenya Madam, and all the participants to be here tonight, and making this program a hit. So after Kashinath started his presentation, it made a little bit easy to start the flow of the entrapment. Now, can you see my screen?
Not yet, ma'am.
Okay, now can you see?
Yeah.
Yes, ma'am.
Yes, it started.
Right. So now when this topic came to me beyond the wristwatch, I was just scratching my head, what is Varsha looking for? And it just amazed me how did she, I hope Varsha has given this topic, right? The name Beyond the Wristwatch, or is it Kenya Madam? Exploring the median nerve entrapment. And it made me think in the last 5 days, how to cover this topic. And as I dealt in detail, I came to know it is just like a Pandora's box. So many things are there which we can see in this entrapment neuropathy in median nerve. I'm just trying to, okay. So median nerve, we know it arises from the medial and lateral cord of the brachial plexus. And which we saw ulnar nerve has only 2 configurations, but median has 5, 6, 7, 8, T1. So how to examine all the nerve roots? Dilemma. So it is more, I think, one of the most difficult entrapments where we can, see whether it is proximal or cervical, coming from cervical or even distal. And it runs down along the axilla, if you see, and medially, distally it runs with the brachial artery and lies between the brachialis muscle and the biceps towards the elbow. So this is a line diagram which shows that it derives these nerve roots. There are no branches in the axilla like the ulnar nerve. In arm, it gives a branch to the brachial artery, and the main branch starts after the elbow. So first branch will be the muscular branch to the pronator teres, then the flexor carpi radialis, palmaris longus, flexor digitorum superficialis. So once all these muscular branches are given up, AIN that is anterior interosseous nerve forms, which is purely the motor nerve of the median nerve. Now, this is very important to know that this is just purely motor over here. And then it continues up to the wrist, where it again gives the cutaneous branch, which is outside the carpal tunnel or the flexor retinaculum. That's how we distinguish, the carpal tunnel syndrome. The palmar cutaneous branch to the lateral two-third of the palm. Then the thenar muscles, first and second lumbricals, and the palmar digital branches which supply the skin of the lateral 3.5 digits. So exactly opposite means the one that's paired by the ulnar nerve. Now, when we see proximal median nerve compression, there are 4 areas or 4 points we need to know where the median nerve can get compressed. The first is the supracondylar process. I will show you the diagram later just to summarize here, where it can be compressed by the below the ligament of Stuthers. Then comes the lacertus fibrosus, which is nothing but a bicipital aponeurosis, where the course of the median nerve is still superficial. Then it goes in the forearm near the elbow joint between the humeral and ulnar heads of the pronator teres muscle, and beyond that in the fibrous arch of the flexor digitorum superficialis muscle. So this slide here is very important from left to right, and this will take most of the proximal nerve entrapment common causes. So right from the left, you can see the supracondylar process here. So it is 3 to 4 centimeter bony spur above the medial opicondyle. It is not present in all the people, but even though it is not present, it may be the Stuthers ligament is there, which may be the cause of the compression. The median nerve runs below it, below this fibrous arch, which connects this bony spur to the medial epicondyle of the humerus. Then as we come just near the elbow, we can see the biceps tendon forming into bicipital aponeurosis. It is nothing but a facial covering, which then connects the fascia of the pronator teres muscle and the flexor muscles of the forearm. And this is a covering below which the median nerve and the artery runs. So there is another potential space for entrapment. As we come below the elbow crease and we reflect the head of the humeral head of the pronator teres and the flexor digitorum superficialis arch, we can see the median nerve dividing into the continuity of the median nerve in the forearm and the anterior interosseous nerve. If you remember, I showed in the earlier slide that it is a pure motor nerve. So here it lies on the ulnar head of the pronator teres. So pronator teres muscle is very important. Okay, it has 2 heads, the ulnar head and the humeral head. The humeral head starts from the medial epicondyle here, attaches to the radius, and the ulnar head starts from the coronoid process of the ulna and goes towards the radius. So in between, it lies in between the 2 heads, and it is a site for compression. Here we have to remember that this nerve, which continuous supply, innervates the other muscles, which I showed you in the previous section, whereas the AIN supplies the flexor pollicis longus, the pronator quadratus, and flexor digitorum profundus muscles. So with this clarity in mind, we come to the next slide, where I again take you from left to right to see how the the median nerve lies in relationship to the ulnar head of the pronator teres. Then as we go further, we cover it. This is the humeral head of the pronator teres, and then comes the bicipital aponeurosis. So I bring you through this again to know, because it is important in ultrasound also, which lies deeper and which lies superficial. So again, to revise, the bicipital aponeurosis, then the humeral head of the pronator teres here, and then the median nerve and the artery, and deeper is the ulnar head of the pronator teres. Now, pronator teres syndrome is common. It is confused sometimes, most of the time, I would say, with carpal tunnel syndrome. Patients get operated for carpal tunnel syndrome. Still 5 to 10% of patients have persistent symptoms, and then they are found to have pronator teres syndrome. Okay. Then lacerta fibrosis is the second most common. 10% of the time, again, it is confused with CTS. More commonly, it was described earlier in baseball players, where they have to throw activity and the muscles get hypertrophied and the facial layer compresses the nerve. Supracondylar process syndrome is not very common, but it can be seen in 1 to 3% of the patients. And as I said, even if the body spur is not present, still the ligament can compress the median nerve. So the symptoms: loss of key and pinch stress, loss of fine motor skills, sense of clumsiness is there in the hand. There is a weakness in the median nerve innervated muscles, which are distal to the lactatus fibrosus. When you compress on the nerve at the level of lactatus fibrosus, there is pain. And there is something called as positive scratch collapse test, which I will deal in the subsequent slides. Patients with this positive scratch collapse test, mainly it is AIN, and they don't have paresthesia. They might have dull aching pain. And if it is in the initial stages, they may just have pain and no weakness at all. So it doesn't mean that the median nerve is not compressed. So we have to pick up early to prevent the neuropathy. So AIN, as I said, it is a motor nerve. And there are prodromal symptoms in this pain also, like it radiates to the shoulder, arm, elbow. It can be aggravated by physical exertion, repetitive activity. Sometimes infection can induce this symptom. Vaccination in pregnancy because of water retention, supracondylar humerus fracture, especially in children, we can see this median nerve neuropathy. When you continuously sleep on a same arm, it can cause pressure neuropathy. There is forearm immobilization or surgery, sometimes unrelated to AIN. That is in case of shoulder arthroscopy. Sometimes it has to be found after the surgery. Patients have these symptoms of AIN. And sometimes there are no apparent causes. We cannot find any cause, still the patients may have the symptom of proximal median nerve compression symptoms. Now, bear in mind, as Kashinath said earlier, we have to do a differential diagnosis and rule out the proximal median nerve from carpal tunnel syndrome, the cervical radiculopathy, and sometimes even brachial plexus compression in thoracic outlet syndrome. So each has its own individual tests. We cannot do all it in this session, but bear in mind that this has to be ruled out. Even the pain which is typical in carpal tunnel syndrome is night pain. Sometimes patients in proximal median nerve, they do not complain. More is seen in carpal tunnel syndrome. More of aching and stiffness is present in the forearm muscles in this proximal median nerve symptoms. And due to the loss of the tone, flexion position of the fingers can be seen, the radial side of the fingers. Weakness can range from, no weakness at all to some limited movements of AIN innervated muscles. So typically it may start with just a sprain and we neglect, it is just a muscle ache or something. And it may aggravate when there is a movement like you do a screw driving or hammering or playing some sports like, tennis or badminton, and can aggravate in forceful activity. So it should not be neglected at that time. So these are the common clinical tests, but I must tell you that these are all the tests, but it may not be possible to differentiate with these tests. Still you have a clinical picture where you cannot diagnose whether it is, compression of the median nerve from where it is coming. So I'll just summarize. So if you remember, here is a Studer's ligament. So pinching here causing pain and distal paresthesia will elicit the test over there. Here is the lactatus fibrosis. So pinching here, pressing the median nerve here should elicit pain and distal paresthesia. Here is the pronator teres and the flexor digitorum superficialis and flexor muscle arch. So it will evoke the paresthesia. But again, all are interrelated. So I don't think that this is much a sensitive or specific test rather. Another one is the OK sign. So you ask the patient to make a pinch like this. If it is a clear O, that means our flexor pollicis longus is working. If it is flattened, that means the flexor pollicis longus is weak. So this is how you can make out in the flexor pollicis longus and flexor digitorum profundus weakness. Other texts are again resistance. So wrist against resistance. So flex the wrist against resistance, flex the fingers against the resistance, flex the distal tip against the resistance or just the thumb, and you can find out minor weaknesses in flexor digitorum profundus, flexor pollicis longus. Even though this weakness is present or not present, if the pain is there at the proximal site, you have to bear in mind that there could be a potential compression. Other test is for AIN, that is for the FBS arch. So you are asking the patient against resistance to flex the finger. This is indicating that there is a compression beyond in the forearm somewhere, not in the hand. This is specific test somehow I feel for pronator teres and Lassatus fibrosis. So first one above here, A is for Lassatus fibrosis. What you do is the elbow is flexed and against resistance, the elbow flex, you have elbow flexion tightens the Lassatus fibrosis here. And as the Lassatus fibrosis tightens, that is the bicipital epineuritis, biceps contracts and bicipital epineuritis tightens, you'll get a distal paresthesia. So resisted movement of elbow flexion is a test for Lassatus fibrosis. And when the forearm is in full supination and you resist the pronation, you compress the pronator teres muscle. And this pronator teres muscle, if it is compressing the median nerve between its two heads, will have distal paresthesia. So these are the two tests for pronator teres and Lassatus fibrosis. The earlier, which I told you, scratch collapse test, which again shows motor neuropathy. Now, here you ask the patient to flex the elbows at 90 degrees and arms are held by the side. Then you externally rotate the arms, which while the examiner is resisting the movement. On resistance, what happens? And after that resistance, you just start scratching the median nerve here or just pinching the median nerve. And immediately after that, again do the test. So at the painful area or at the site of compression in that hand, the rotation against resistance, the arm will collapse. Whereas this normal side, again against resistance, the arm will not collapse. So this is how this is mentioned in the literature, but I have not done on patient anytime this scratch collapse test, but it was mentioned, so it is my duty to tell you here, so we can try it next time the patient comes. Okay, now this is the era of ultrasound. So I do believe in ultrasound, and whenever clinically we get a diagnosis, we should always confirm with ultrasound like a stethoscope. So I will go through the slides of pathological slides of median nerve compression, proximal ones at various, which I have got from the journal article of ultrasounds. So now this is a sono image showing the supracondylar process. So if you remember 3 areas, so this is the how do you say it is a supracondylar? I'm not shown the probe position, but this is the X-ray showing the supracondylar spur. And you can say posterior anacoustic shadowing. So this is a bone. And here you can see the median nerve here. This is the Sluther's ligament. Okay, and this is the brachial artery. So compression against this spur and the ligament, repeated it can cause compression, like how you have in cubital tunnel syndrome. Similarly, median nerve can get compressed here. Supracondylar process syndrome, this is called. Then once you know the normal anatomy, it is easier to find the pathological anatomy. So this is the normal anatomy of pronator teres. How do you find the pronator teres muscle? So right at the humerus, the humeral head of the pronator teres inserts or starts. Below it is the brachialis muscle. Okay. So as you come down, so this is in the distal part of the arm. As you come down towards the radial head, this is the belly which thickens. So this is the smaller belly, and this muscle becomes more chunkier. This is the humeral head of the pronator teres with the median nerve and the brachial artery. Below there is a brachialis muscle attached to the humerus. So this is the normal looking muscle. Now this is at the elbow crease. When you see the ulnar head starts coming from the radial, from the ulnar side towards the radius. So this is the deeper one, which is the ulnar head of the pronator teres. This is the humeral head of the pronator teres, and median nerve lies in between. This hyperechoic bright vesicular structure is the median nerve, and there is a chance of compression at this site. But you have to trace it distally till the attachment to the radius. So both the heads, they combine and get attached on the radial side. This is the muscle. This is the brachialis muscle on the top, and there's the neurovascular bundle. This is a supinator muscle coming here. This is the forearm. right, if you want to trace right from the medial epicondyle, the humerus, pronator teres, then going down the coronoid process of the ulnar head starts coming. So these two muscles, they combine, they become single muscle. This is the sheath in between, and it becomes one belly and gets inserted onto the radius. This is the pronator teres insertion onto the radius, the longitudinal section. So once we know this normal pathology, then we can find the abnormal pathology. So this is the abnormal pathology, where you see the median nerve is compressed between the humeral head and the ulnar head. This is the hypoplastic ulnar head of the pronator teres, small muscle you can see here, and the ulnar artery lies below here. This is the Lasata fibrosis. If you remember, it starts from the continuation of the biceps tendon and merges into the fibrous sheath going over the pronator teres and the flexor muscles. So this is the Lasata fibrosis. This is normal. These are the vessels, and this is the median nerve over here. This is how it should appear. So if we know normal, we will know if there is any abnormality.
Ma'am, 5 more minutes, ma'am.
Okay, fast.
Yes, ma'am.
So this is the oblong median nerve, which is compressed between the two heads, and this is normal looking now. Okay, so same patient, when you go down and see the flexor muscles, because the nerve is pinched and there is motor neuropathy, this is the hyperechoic hypotrophy of the flexor digitorum muscles, whereas this is on the opposite side, normal looking muscle. Same way in IV fistula patient, if they complain of pain, just put an ultrasound and you may see a median neuroma here. This is a musculocutaneous nerve neuroma. This is another patient with medial collateral ligament thickening, and when it is transverse scan with the condylar process, there was enthesiophytes and echoic shadowing. So when we do axial scan, we could see the injury to the pronator teres muscle, avulsion injury, and it is continued in the Lasata's fibrosis also. Anomaly can be there in the median nerve. It can be away from the normal position. So this is right near the elbow crease, you can see. So every time you do the elbow movement, this nerve will get affected and potential site for entrapment and neuropathy. Carpal tunnel we cannot do without. So we all know carpal tunnel. So flexor retinaculum attached from scaphoid tubercle to pisiform and trapezius tubercle to the hook of Hamet. Now carpal tunnel, we must remember that we differentiate it from the medial proximal nerve syndrome because all the forearm muscles and all tone, power, everything is normal. There will be a sparing of the palmar aspect of the skin sensation because the palmar cutaneous branch, if you remember, it is given out before the median nerve goes into the flexor retinaculum. So 3-4 things you see in carpal tunnel. One is the diameter or the circumference just located proximal to the tunnel, located at the pisiform level bone, and one is at the Hamet level. So we call it proximal, distal, and the middle. And then the difference you find out. So that's how we calculate the circumference and area of the median nerve. So this is something called as flattening ratio also is found. You can look into the references I will show you because in lack of time we cannot do in detail. But these are very important when you want to say that, okay, the patient is suffering from carpal tunnel syndrome and there are sonographic findings because sometimes nerve conduction studies may not be equivocal or symptoms may not be matching with the carpal tunnel. You are in confusion with the diagnosis, but ultrasound may help here. Very important thing is when you measure the circumference, don't measure the outside hyperechoic bright white line sheath because that should be avoided. Otherwise, you may get false positives. And always compare to the opposite hand. So in opposite hand, sometimes big median nerves are there in patients in both the hands. So it should be okay for that patient, right? So we all know about the tendons, flexor tendons, 9 tendons going below, and the nerve is superficial. It can compress over here. Tingling symptoms of fingers and hands and thumbs, electric shock-like sensation. Sometimes it goes above in the elbow also up to the shoulder. And main is weakness of the hand. Patients, we cannot wait till dropping of the objects happen. Even the initial symptoms, we should try and address the patient. Clinical signs are Tinel signs. We know how to tap the nerve and you get paresthesia. Phalangitis at the shoulder level, you have to ask the patient to hold the wrist at 90-degree flexion and then hold it for 30 to 60 seconds, which induces the paresthesia on the median nerve area. It can be compressed by tenosynovitis. Okay, the fluid around the tendon will compress the median nerve. So ultrasound will be helpful here. Flexor retinaculum itself can be thickened and it compresses the nerve. There is something called as Palmar-Boeing sign of the flexor retinaculum. You measure at the level of the trapezium bone and measure the distance between the two. That's how you know whether there is flexor retinaculum is bowed or not. These are the Doppler signals, positive. Very important here, so you get this narrowing constriction when you see the transverse scan of the median nerve, and there is proximally there is thickening of the median nerve. And in carpal tunnel syndrome, we do get this, and we should look for this and in ultrasound. Diagnosis, again, clinically, history taking, examination, x-rays to see any bony spurs or tumors, mass. Ultrasound, like a stethoscope, as I said, must by the bedside to differentiate. MRI, sometimes even carpal tunnel syndrome may not be detected on MRI as well. Nerve conduction studies and EMG to your diagnosis. Management, again, we discussed about various conservative management is a part of it. You try conservative, not helping, then go for interventional and then surgery. Interventional, we do injections as it was mentioned with ulnar nerve, same hydrodilatation around the nerve. And when you're in confusion, do diagnostic blocks. You can give 0.51 ml and do diagnostic injections if the diagnosis, you want to confirm your diagnosis, and then go for the hydrodilatation. These are my references for all these pictures and pathological images of ultrasound, if you want. And thank you. I'm open for questions. It was very less time, I must say. It is a vast topic. I mean, more than ulnar or radial, median nerve is like it was opened so many things up. I still feel I've not done justice. I had to brush through it very fast. But
yes,
anyways, yeah.
Yes, ma'am. Thank you for the very informative and detailed lecture. Any questions?
I have a question, Surbhi.
I knew it.
Surbhi, wonderful presentation. Thanks for that detail, and many things opened up for me also. These patients come a lot, so we have queries. My question is that is there any guideline that which patient will benefit from hydrodilatation and which will require surgery? Because few of my patient did respond to intervention and few of the patient didn't respond, and I had to ask them to undergo surgery. So any literature anyway, because when I searched, I didn't found anything. So much of a diameter of median nerve when you subject for surgery, or so as we go, like do first hydrodilatation or intervention and then go for surgery. But the patient loses that much time and suffers in pain. So is there any guideline for that?
So that's right, madam. There are no guidelines as such. But as you said, when they come with a frank, muscle, we have this hypothinner eminence and thinner eminence to check. They already atrophied, and you see the median nerve, which is, bulky and compressed and a severe compression. Straight away, I would request you send for surgery.
Yeah,
but if it is
that is very clear.
Yeah.
Yeah, that is very clear. The initial stage and the last stage, those are very clear. I mean,
correct.
Initial stage we do hydrodilatation, and last stage we naturally straight away advise to go for surgery. The in between stage, like the patient has symptoms for 1 or 2 months, more than 2 or 3 months, those are not very severe also, but not very mild also to neglect. So,
yes, so
I couldn't find any guidelines.
Yeah, there are no guidelines, but I can say from our experience that our colleagues also, orthopedic colleagues also, they, have conservative therapy. They will do stenting or physiotherapy. So why not we try, intervention in the meantime, and if the patient gets benefit and go for physiotherapy and it avoids surgery, well and good. So that is my approach when carpal tunnel patient comes in the mid.
Yeah, the way we all do. I mean, got that. And any preference of the solution?
So initially, I was, if it is frank, I feel there is a compression and edematous looking, or tenosynovitis is the problem, then I go for corticosteroid. If just median nerve and, there are not much inflammatory signs, we can try with 5% dextrose also. PRP so far, I must admit, I'm not put for carpal tunnel syndrome. But yes, I've tried 5% dextrose and corticosteroids.
Right. Yeah. Thank you, Surbhi.
Thank you. Thank you for this opportunity.
Ma'am, I had a question. Ma'am, pregnant patient with carpal tunnel syndrome.
Archana, I didn't get the question.
You give before going for? Oh, sorry.
I can't hear you, Archana.
In
Can you repeat the
pregnant
question?
patient with.
Archana, repeat.
Yes, ma'am. Can you hear me now?
Now
Yeah.
I can hear you. Yes.
Can you hear me now?
I can hear. Yes.
Okay. Ma'am, yes. Okay. In pregnancy, who has a carpal tunnel syndrome, how will you treat her conservatively? Means before going for an intervention, conservative management in pregnant patient, other than splinting, medicines wise, what you will give her,
So medicine,
in a pregnant patient.
Yeah. So which trimester, first trimester, we don't do anything, just send for physiotherapy or, just splinting. And sometimes we try TENS also. TENS therapy helps in patients of carpal tunnel syndrome. That is what you can try first trimester. Second, third trimester, where you can give non-steroidals, you can treat with that.
Thank you.
Is my presentation seen?
Yes, sir. Please go ahead.
Okay.
Yeah.
Should we start? Yes. I think
Yes,
I'm a bit late as well. Thank you for the opportunity. See, we are actually going to discuss about radial nerve entrapment. Like as I keep saying, when it comes to nerve entrapment, what the mind does not know, the eyes do not see. That is what is called nerve entrapment. So there are quite a lot of these theories which we actually see with respect to nerve entrapments, like how to diagnose, what exactly to see. Many times we have come across these patients. Probably we miss these patients also. That is also true. So what we need to understand here is, whenever there is a suspicion of any particular nerve syndrome, it's always prudent to actually complement your diagnosis, clinical diagnosis, which you actually arrived by your history with proper high resolution ultrasonography, plus a nerve conduction study before you actually go for any further treatment. And secondly, the smallest micro points, like where exactly the entrapment is. Say, for example, something like a Guyon's canal entrapment of the ulnar nerve. It's hard to differentiate between like where exactly the entrapment has happened, and it is hard to actually treat also. So the hydrodissection can happen at anywhere, whichever level the entrapment is. But in a longer course of the nerve, it is always prudent to look for high resolution ultrasonography prior to any intervention. So what is the anatomy of this nerve actually? We are looking at the spiral groove where we have probably you could have there is a spiral groove. You can see the radial nerve which is passing medial to lateral. We'll see the anatomy later on by ultrasound and by illustrative pictures. The distal arm, again, the radial nerve pierces the intermuscular septum to become anterior, the anterior aspect of the humeral lateral condyle. Then we have a couple of branches, the superficial sensory and the deep motor branch. The superficial sensory branch runs in the forearm along the deep surface of the brachyradialis, whereas the radial tunnel, which contains the deep motor branch, actually, it's at the level of the radiocapitellar joint to the proximal aspect of the supinator muscle. Now, again, we need to understand what is the radial tunnel. Again, we'll see the boundaries. It is bounded by the joint capsule posteriorly, medially by the brachialis and the biceps tendon, and laterally by the brachyradialis and the extensor carpi radialis, brevis and longus. The deep branch pierces the supinator, whereas at the exit, from the supinator, it is called the posterior interosseous nerve. Again, where all it supplies the muscles, the individual muscles which we need to see, the triceps and the anconeus at the level of the upper arm. At the level of the radial tunnel, you have the brachioradialis, the extensor carpi radialis, longus and brevis, and of course the supinator. And the posterior interosseous nerve supplies the dorsally located extensor muscle. So when we understand which muscles are involved in any particular syndrome, any neurological syndrome, probably we'll be able to come to a conclusion where exactly is the compression site. So this is the exact positioning of the radial nerve, the illustrative picture, starting from medial to lateral and along the spiral groove. Where we have the pictures, you have a small little artery which is accompanying there. That is at the level of the spiral groove. You could see this almost abutting the periosteum of the humerus posteriorly. And this is at the exit from the spiral groove. This is where which we call the compression at this site, which we call it as the Saturday neck palsy. This is to explain about the boundaries of the radial tunnel. You could see the radial tunnel is actually starting from here and it ends at the proximal level of the supinator. Here, you could see there are a couple of branches, the deep branch, that is the deep motor branch, and the superficial sensory branch. This basically has the boundaries like this. Medially, it has the biceps and the brachialis. Laterally, the brachioradialis and the ECRB and the ECRL. Distally, you have the supinator, and proximally, you have the radiocapitellar joint. This basically is the region which is called the radial tunnel. At the level of exit from the supinator, this deep motor branch actually is called the posterior interosseous nerve. Now, at the level of the extensor compartment 1, you could see this is the extensor compartment 1, over which you can see the first, that is the extensor compartment 1, you could see the sensory branch of the radial nerve. And this is a potential threat for any IV cannulation on the cephalic vein. So we really do not take care of this actually. We just cannulate. It is something called the anesthetic vein. How many times we have really injured the radial nerve, the superficial radial nerve, we really do not know. So some people really, they do complain of some amount of paresthesia because the injury to the superficial sensory radial nerve. Again, this is some picture which I have taken from one of the internet slides actually. This is the APL and EPB tendons. You could see the cephalic vein and very closely you could see the superficial sensory radial branch. So this is exactly the point where this can get injured. And again, this is another point. This is the cephalic vein compressed. You could see with compression with the ultrasound probe, you could see the nerve. This is something which is visible only with high resolution probes. So good ultrasound machines are absolutely mandatory. Again, radial tunnel syndrome, the difference between the radial tunnel syndrome and posterior interosseous nerve entrapment, it is very, very important to realize, recognize, and then treat. So the compression of the deep branch of the radial nerve, mostly it causes a painless palsy of the extensor muscles. Whereas, in contrast, the posterior interosseous nerve entrapment is always associated with motor weakness. So if there is a finger drop, this is a posterior interosseous nerve entrapment. If there is no finger drop, if there is only a radial nerve injury, then it is called the radial tunnel syndrome. So motor function is not a feature of, motor dysfunction is never a feature of radial tunnel syndrome, whereas posterior interosseous nerve entrapment, there is always something called motor weakness. This motor weakness, there can be an episodic forearm pain sometimes, but weakness is mandatory to make a diagnosis of pin entrapment syndrome. So what is the etiology here? So what are all the factors which can cause? Mostly repetitive overuse of the forearm. Either it can be a flexion extension or a supination pronation, which can cause a radial nerve injury at different levels. It can commonly occur in tennis players. The thickened and hypertrophied anatomic structures which can entrap the nerve are the arcade of Froese, that is the proximal tendinous edge of the supinator muscle, the thickened leading edge of the extensor carpi radialis brevis, the distal ligamentous margin of supinator, and the arcade of Froese is the most common site of compression. So all these are potential sites of compression. So this basically is visible only with a high resolution ultrasonography. So what are the space occupying lesions which can cause entrapment like picture are a tumor, a simple ganglion, or a bursitis, a bicipito-radial bursitis. Sometimes prominent recurrent radial vessels at the proximal radial tunnel, a facial band which is connecting to the radial head, or sometimes in systemic illnesses like diabetes, rheumatoid arthritis, and neuralgic amyotrophy. All these are potential conditions where the patient can develop a radial tunnel syndrome. So what is Wartenberg syndrome? So all these are named syndromes which we sometimes fail to pick up because we really don't look out for it. This can be easily associated either with a decurvence or an intersection syndrome. So what is this? It can actually present with numbness, pain, and paresthesia on the radial side of the wrist and thumb. Most often than not, it will always be associated with either a decurvence or an intersection syndrome. It can be associated with a trauma or sometimes a Colles fracture fixation, and more commonly with IV cannulations, sometimes physical activities, repeated physical activities that require forearm pronation, which with associated ulnar deviation. Again, this can actually lead on to something called the Wartenberg syndrome. All this can be diagnosed by help of ultrasonography. So these are some of the images because like I always try to share my images. See, this is a long axis view of the posterior intraosseous nerve into the supinator. You could see the supinator on its long axis. This is the head of the radius, the superficial and the deep heads of the supinator. And you could see there is a small dilated segment. This is always seen as a tube. This is a monofascicular nerve. That's the posterior intraosseous nerve. And this monofascicular nerve is always, means like there's a little dilatation. Sometimes this can be normal, this small little dilatation, but a localized focal dilatation is indicative of a pathology, right? This is a publication by Dr. Kevin Chang et al. And this is a rare case of postpartum forearm pain with diffuse enlargement. You could see the diffuse enlargement than a focal swelling. This is because of repeated resting of the baby on her forearm. Okay. Again, how do you actually look for the posterior intraosseous nerve or the radial tunnel, the deep branch of the radial nerve? So basically what we need to understand here is, you could see there's a radial nerve there. This is the superficial branch of the radial nerve. And you could see there is another branch which is entering into the supinator. That is the deep branch. And that's the exit of the deep branch of the radial nerve. So basically you need to trace. And if you keep a static image, you could see the supinator there, the superficial and the deep heads of the supinator. And that's the radius. And you could see there is a small nerve, the monofascicular deep branch of the radial nerve in the fibrofatty plane between the two heads of the supinator. You could see this here. This is a very nice picture from a different machine. You could see the radial head, the supinator, the superficial sensory branch. That's a deep motor branch, a tubular deep motor branch. That's the exit of the nerve. And at the exit of the nerve from the supinator, it is called the posterior intraosseous nerve. Again, for all practical purposes, any entrapment syndrome, you should always do a hydrodissection. Never do any pulsed RF or any radiofrequency ablations. That is not indicated at all because entrapment syndromes are to be hydrodissected. This is the nerve here. You could see the short axis of the nerve, the in-plane needling. That's the nerve there. I'm trying to hydrodissect with 5% dextrose. You could see the nerve hydrodissected. This is one other picture. This is an electrician who presented with a chronic lateral elbow pain. Again, this is one of very, very common differential diagnosis for a lateral elbow pain. You should never mistake all lateral elbow pains are due to lateral epicondylitis. So always have something in mind. So you could see the needle coming in. That's a long axis of the nerve. Giving 5% dextrose above the nerve. And this is injecting around the nerve, that is above the nerve as well as below the nerve. The only advantage of using 5% dextrose, see, you could see below the nerve also it is spreading. The only advantage of using 5% dextrose, see, some amount of 5% dextrose has already gone into the muscle. So it doesn't matter. It does not harm at all. Sometimes it can go a little intraneural. Again, does not do any harm because the entire pathology lying with any entrapment syndrome is disruption of the blood-nerve barrier. So this basically does not do any harm even if you inject a little intraneurally. This is another very interesting case. Again, this was done a couple of years back. A patient who presented with a finger drop post Galeazzi fracture, that is 3 days later, the patient presented with a Galeazzi, after Galeazzi fracture fixation, finger drop, you could see, I will give you the pictures there. You could see, I'm just holding his wrist. There's no wrist drop at all. There is only a finger drop. So what does that indicate? That indicates only a posterior interosseous nerve entrapment by the screws. That was actually only the third screw which was actually giving entrapment of the. See, you could see there is the third screw there. You could see there is that's a posterior interosseous nerve and that's a supinator there. It's little difficult to see the implant. You could see the implant there right over the radius actually. This is exactly the reason for the entrapment. So we decided to go for removal of the third screw, which could have probably given her better the finger drop could have actually come back, but the surgeons actually decided to remove the entire implant and go for a conservative management, which was always good. So this is another thing which I wanted to tell you. A patient with decurvent stenosynovitis, you could see there is fluid around the couple of tendons, that is APL and this is the APB. You could see the fluid around, there is a superior extensor retinaculum, and you could see there is a small little nerve. That is the superficial branch. That is the sensory branch of the radial nerve. You could see there. Okay. You could see the cephalic vein. Is it not very easy to injure it? Very close by. So it's very easy to injure it. So we are unknowingly injuring quite a lot of these superficial radial nerves daily. This is exactly the one. So again, deep branch of radial nerve. Two distinct syndromes have to be differentiated. One is the posterior interosseous nerve syndrome, which is again with neurologic symptoms, radial tunnel syndrome without neurological symptoms. So what constitutes a radial tunnel? The definitions, everything we have studied. And sometimes these radial tunnel syndromes have other coexisting diagnoses. So before any intervention for any of these syndromes, always try to do a proper ultrasound, make a diagnosis, and then go for the intervention. The PINS, that the posterior interosseous nerve syndrome, involves much more palsy than pain and should be considered as a distinct nerve disorder and often caused by abrupt trauma or space-occupying lesions like a ganglion or a lipoma. So what is the role of ultrasound here? You could do a proper nerve tracking, identify the site of entrapment. You could see the nerve size, compare it with the opposite side. You could look for pathologies, the space-occupying lesions. You could do a Doppler and see if there is any severity of the lesion. That is like increasing severity means that there will be increasing Doppler signals within the nerve. And you can plan your interventions. And as we discussed, the muscles which are supplied by these individual nerves, which we have discussed, these nerves, means these muscles actually go in for fatty degeneration if there is a long-standing entrapment. Thank you so much for the opportunity. I think I did a small little discussion of fatty, means like entrapment of the radial nerve. Basically, what I wanted to insist here is we need to know that there is something which we should keep in mind, then we need to see. What the mind does not know, the eyes do not see. All the lateral elbow pain must always be looked for something involving the radial nerve. Thank you so much. And I just wanted to tell you this. without which, like, I think, like, I cannot complete this lecture, Dr. Varsha. We actually are holding this MSK Pain Congress. This is the second MSK Pain Congress, which is going to be held in Chennai. And this is going to be in January 26 to 28. We have the most, means like a wide array of faculty.
Hello.
Hello.
Hello. Is he audible? I was not able to hear. Madhan sir?
No, he's not audible. I think he's just showing the slides. I don't know.
Okay. Yeah, he just.
Thank you so much.
Okay. Thank you so much.
Thank you so much, ma'am. Actually, like, I thought, like, I'll just put across this forum, actually, because most important, like, we have really fallen short. It's like COVID has created havoc. A lot of online learning, which is not serving any purpose. So we just wanted to do something, actually, like, for pain education in India. So we have called up nearly some 15 international faculty and around 50 faculty in all. And probably next year, we really are actually going to look forward to include fluoroscopy tracks also. So probably, like, we'll see, like, something good coming for India.
Thank you very much, Dr. Pandian.
Thank you, madam.
It's a very, very interesting lecture. And actually, I was wondering if you could share your faculty with the ISSP Con, which is there right next week. I guess some of my juniors have been trying to get in touch with you.
Actually, Dr. Uttam had actually messaged me today. Yeah.
So if you could, you, of course, we are going to hijack you anyway, no matter what. So, but I was wondering if you could have Andrea Trescott or somebody who's visiting and
yeah, sure, madam. I'll share.
Faculty, if you can arrange, if she's staying back, we would love to have her for the conference.
Actually, she is flying back on 29th, 28th.
I see.
Actually, like, the only issue is, like, you know that we are a very new society, so we have a very little funds to work with. So very little funds to work with means, like, we booked all their tickets with a non-refundable ticket. So a non-refundable ticket, and they are returning back on 28th. Actually, that's the last day of our conference. Actually, I'm not very sure how much we can do to actually reorganize the ticket. Let me see, ma'am.
I would appreciate, and I guess the organizers can get in touch with you and we can discuss this.
Sure. I'll just do the needful. I'll try and connect with the travel agent so that, like, if we can do something about the rescheduling of the travel, probably yes.
Certainly, and lovely lecture, and would like to interact more with you.
Thank you, madam. Thank you.
Thank you, sir, for the lovely lecture. And we enjoyed your case presentations as well.
Okay. Thanks, ma'am.
Dr. Madhan coincidentally matching with your slide design.
Okay.
In continuation with your lecture.
Yeah, ISSP also. Yes.
Yeah. Thanks. So this is what now we are also getting geared up for ISSP Con 2024. Okay, Archana, do you have any questions for Dr. Madhan?
There is one question in the comment box.
Yeah.
When is NCV study done for detecting entrapment at the usual sites of compression? What is the indication?
No, actually, if that's what I told you. No, like, there was a patient who had a finger drop, and we really had to do a nerve conduction study before we actually go in for any intervention. And as we know, all of us know that actually we really can't look for the site of entrapment with a nerve conduction study. I think, like, you will all agree. To look for the site of entrapment, to look for where the pathology is and what the pathology is, you require ultrasound. So what I tell you is, if you suspect entrapment, always do a nerve conduction study, always do a high resolution ultrasound, and if required, an MRI also for a small nerve. Like, see, today I had a patient. Let me take another 2 minutes actually. Today I had a patient. See, you could see, you know that there are some barrels, like the big barrels are there, no? In a kerosene shop or something like that, no? Like they have arranged some barrels. This fellow was working there in a godown, and one of his legs actually went in between the two barrels. In between the two barrels, in the sense, like he started developing severe, what to say, like neuropathic quality of pain, starting from his buttock. So everybody starts treating it as a case of acute disc prolapse. Everybody has started treating it as a case of low back pain, acute disc prolapse, follow. But means like as usual, like the MRI showed something like a disc bulge. Like then I had asked for a MRI of the sciatic nerve. Sciatic nerve MRI shows demyelination injuries because of, typically he had a scratch on his buttock and then he got up. So it's like that actually, like nerve conduction study, and sometimes even an MRI may be required, a focused MRI, and trying to find out where the pathology is, then go for the intervention. Basically, that's what I kept telling you. Hydrodissection, the intervention part, I think most of us will do. The only thing is that diagnosis aspect actually. So always do a nerve conduction study. Never compromise on a nerve conduction study. Never compromise on a good ultrasound study. And if required, an MRI, focused MRI of the individual nerve is absolutely mandatory.
Okay, sir. Thank you.
Thanks.
Any other questions?
No questions now.
Okay.
Thank you. Thank you, madam.
So I would like to conclude the session by thanksgiving to our eminent speakers, Dr. Madhan Pandian, Dr. Surbhi Bhagat, and Dr. Kashinath Bangar. Especially as you all are seeing, we are busy in the preparations of ISSP Con. And then it was very last minute, 7 days prior, I actually talked to every speaker.
You told me 2 days back.
Yeah, you were the...
But you were talking to the wrong person as well.
That was a big miscommunication. We got some other number which we thought is Dr. Madhan. And I don't know how it happened. Even that person has responded. And then we got the correct number, and Dr. Madhan was roped in just a couple of days prior when our flyer was out. So I really want to acknowledge every speaker. Without doubt and without hesitancy, they really jumped in, though it was little late on my side to approach them. And with such a wonderful talk, excellent slides, finished within a minute, very crisp message. So thank you, sir. Thank you, Surbhi, and thank you, Kashinath. And I want to thank our media partner, Anesthesia TV. They are always crucial and very efficient in taking these webinars by SSPP on 5 platforms live at a time. So thank you, Mr. Rahul and team. And our SSPP team, who is always supporting and standing and participating in this discussion, all society members, and our audience all across the globe, joined from different states of India and outside as well. I was just watching on our YouTube and Facebook live. So everywhere I was having, at any given moment, 30 to 40 live speakers, live audiences. And this is what we are doing since 3 years of COVID, online webinar by Society for Study of Pain. As Dr. Madhan has said, because of COVID, there is a lot of online learning. And this is what has kept us bound together in a busy city like Pune, where it's really difficult to commute for every physical meeting. This has created the possibility of continuing academics. So thank you, Dr. Varshali ma'am, Dr. Madhuri ma'am, and all our seniors for guiding us. Have a good day and happy Ganesh festival.
Okay, thank you.
Thank you, Varsha. Yeah, thank you, Dr. Madhan.
Thanks,
thank you,
Dr. Kashinath and Dr. Surbhi. And thank you, Archana, for a wonderful moderation.
Archana is our
Thank you.
girl.
See you all at ISSP Con.
Yeah.
Thank you. Bye-bye. Good night.
Good night.
Bye and good night.
Night.